All right, welcome everybody. My name is Robert Milad and I will be your host. I'm the Chief Academic Officer for ITX Pros. Today is our first part of our four-part webinar of live planning with Dr. Resnik on how to navigate through the mandibular anatomies. We have today Dr. Randolph Resnik, the director of the Resnik Implant Institute. He is no stranger to you all. And so we are going to get started. We have just a quick slide on ITX Pros and the Resnik Implant Institute. ITX Pros is a team of dentists and engineers who have over 200 years of collaborative and collective experience in digital dentistry. We work on guided surgery, all on X stackable guides, as well as radiology reports. We really can provide you with all your needs when it comes to digital dentistry. We have a dedicated phone line, live support, and we try to, turn around your case as soon as possible because we know that's important. On the other side, we have the Resnik Implant Institute, and we have Dr. Randy Resnik. He was no stranger to any of you guys. He has over 35 years of educating dentists in implant dentistry. He has the Resnik textbook that all the universities internationally and nationally use on implant dentistry. He has several credentials with fellows, masters, and diplomates in a bunch of implant organizations, and he is really just the genius and mastermind behind the Resnik Implant Institute. And, he is the go-to person when you want to learn about implant dentistry. Right. So this is our kind of our schedule for our upcoming webinars as well, where part 2, we're going to talk about treatment planning in the aesthetic zone. And then part 3, navigating around the maxillary sinus. And then part 4, we're going to do the totally edentulous mandibular planning. So we'll have a webinar every month, get your CE credits in, and we have several of our faculty members on here. So we have Dr. Christopher Resnik, who is also part of the Resnik faculty. We also have Tara Resnik, Dr. Rick Robinette, as well as Dr. Hussein and Dr. Sarah Amin, who will be answering any of your guys' questions that you might have. So there is no presentation for this webinar. However, if you have any types of questions, if you scroll or hover over the bottom of your page, you will see a Q and answer tab. Please click on that, submit your question. You're capable of seeing both the questions being asked to the panel, as well as those that are answered or dismissed. We will try to answer as many as possible and save some of those questions for Dr. Resnik. And so without further ado, I want to hand this over to Dr. Hussein and, of course, Mr. Implants himself, Dr. Randy Resnik. Thank you, Doc.
Thank you, Robert. Okay. Okay, Hussein, before you start, let me just say, welcome everyone. I would highly recommend as we go through these cases. So what we're going to do is just start going through cases one by one. We're going to talk about the medical history, treatment plan. We're going to actually look for any variant anatomy. We'll place implants, we'll place prostheses, but please use that Q&A button. We have 5 faculty that are just waiting to answer questions, and they I want to put them to work. So please ask some questions, and I will go over any ones at the very end, but let's try to keep them busy. So with that being said, Hussein, let's go over the first case. Can you tell me a little bit about this patient?
So Doc, I was going to bring on Dr. Paras, if you don't mind.
Oh, okay. Perfect.
I was going to call on him. So give me 1 sec. Dr. Paras, can you hear us?
Yes, I can hear you.
All right.
I can hear you.
Great. Can you please present your case for us?
Yes, so this is a 42-year-old female that would like an implant in number 19 area. She's healthy. She has controlled hypertension. That's it. The tooth was pulled a long time ago, not by me, by another dentist. So there is some resorption of the buccal. So that defect has me a little concerned, but yeah, I'd like to get Dr. Resnik's opinion on it.
Okay, great. So Hussein, why don't we let's take that tooth out that you have in there and let's do a 360. So let's look at it from the occlusal view. So right off the bat, what I like to do is, Hussein, can you remove all the teeth, please? So just by looking at the morphology of the ridge, once the teeth are removed, is you can see there's a significant concavity there into that edentulous site. So as Scott has said, this patient's been edentulous for some period of time. And remember, we always lose bone from the buccal to the lingual. So this is rather significant resorption. One of the problems that this poses with us is when that ridge resorbs from the buccal to the lingual, that usually means our implants are more lingually oriented, which can cause an issue with the prosthesis, mainly impinging on the tongue space. And then also if there's a sublingual undercut, this could be very difficult without significant grafting to do a case like this. So with that being said, Hussein, let's do a 360 so we can look at that sublingual area on the, okay. So there is a little shelf of bone, but we do have probably a little bit of a concavity, 10, 12 millimeters from the crest of the ridge. Okay, so let's go ahead, put the teeth back in. And let's look at it from the facial aspect. So hold it right. Let's look at the lingual there, or the anagonial notch. So show them the anagonial notch. So is this a female or a male? Did you say female? Female. Okay. So this patient has a little bit of pair function. Have you noticed that? Or so where Hussein is putting his cursor, that is called the anagonial notch. And usually that is straight. So we have our masseter muscle that inserts into that area. Whenever you see notching in that area, that usually means masseter hypertrophy, which is consistent with clenching and or bruxing. So with that being said, we just have to know that we may have some higher force factors here. Then we'll certainly look at that when we go ahead and plan it. So the next thing I want you to do, Hussein, let's go ahead and let's look at a pan view of this. Okay, so you've already drawn in the nerve. Okay, so the next thing, Scott, is what I'd like to do is evaluate this nerve, the path of the nerve. So for some of the other doctors on, there is 3 types of nerve paths coming from posterior to anterior. So the first path is what is called a type 1, which is very high up. It's very close to the apices of the teeth. The second is in the center of the mandible, and the third hugs the inferior border. Now, even though that I believe this is just the angulation of this Panorex, but that molar tooth, even though it looks like it's goes to the inferior border, that's probably just the angle that this pan is taken at. So if we look at the course of this nerve, oh no, it is okay. So wow, that's a long root on that molar. So even though that this is hugging the roots of the teeth, the anomaly here is the actual root length. So if we look at the actual nerve trunk, it is going to be what we call a type 3 nerve because it does hug the inferior border. That is always a very friendly nerve to us because it will be in the lower 1/3 of the mandible, and that will give us more available bone for implant placement. So why don't we look at a cross section through this edentulous area, and let's see how much bone we actually have. So as you can see, what Dr. Hussein has done is he has placed a tooth that will coincide, the central fossa will coincide with the lingual cusp of the maxilla, which is the plunging cusp of the maxilla. So that is our outline of our tooth that we need to replace. So he is measuring that for me. So from the top of the ridge, we have 11.6 and then about 6.6. So we know that we probably can't get an implant to that very crestal area. So Hussein, have you put an implant in on this case? Oh, you have? Okay. So that looks like it's a 5x10. Okay. So with that being said, as I said, there's a little bit of a lingual undercut there. Well, actually pretty significant undercut. So the problem that we have on this positioning of this implant is it is way too close to that lingual cortical plate. The one complication that can arise from perforating that lingual cortical plate is you have the submental artery in that area. And if you perforate into that space and possibly traumatize that artery, then you can end up with sublingual bleed, which ends up floor of the mouth swelling, lingual hematoma, and then you have a real significant problem. So the second problem with putting a 10mm implant in is when you drill into that cortical plate on that lingual, what ends up happening is usually it will deflect the drill a little bit. So you don't have much margin of error on this case at all. There's very, this is pretty compromised bone. So the question is, you could, where you place that, Hussein, I like that positioning because it does go to the lingual cusp of that maxillary posing tooth. However, I think we have that implant's a little bit too long. So this is a Hahn 5x10. They also make a 8. So let's look at an 8. Okay,
Here.
I think that's a lot better there. So as you can see here, we're not going to even get into maybe a little bit into the cortical plate. So you won't get any deflection. You will not be what we have 1.5 millimeters.
Yes, sir.
So I think Scott, on this one, that putting a 5x8 would make a lot more sense. So you might ask the question, well, why would you even want to put a 10mm implant in there versus an 8? Well, let's say if we didn't have primary stability, that's when we want a longer implant. But the biomechanical advantage of going to a 10 other than primary stability is very minimal. Therefore, because we have cortical bone, and as we all know, we get the majority of the primary stability from the cortical bone, I think you'll be able to place this implant within the confines of that lingual plate, and you will have no chance of perforating the lingual into that sublingual fossa that could be very dangerous. So that leaves us to the next problem is the width. Do we have enough buccolingual width to place this implant? So if we look at number 19, if we look at that tooth, usually that the mesial distal diameter of a lower first molars between 10 and 11 millimeters. So we certainly don't want to go down to any smaller diameter implant. Ideally, we want between a 5 and a 6 millimeter implant for a molar, and that will give us proper emergence profile. So on this case, you have two options. One option would be to build up the bone a little bit with a guided bone regeneration and build up the ridge. Do a ridge augmentation as phase 1, come back and place the implant phase 2. The second option would be to place this implant, and then at the time of placement, I always prefer to take some of the bone from the actual surgical burr, and then you pack that buccal plate just where he's showing you right here. And ideally, you decorticate it a little bit and put some autograft with a little bit of allograft, put a collagen membrane over top of that, and I think you should be fine. If the confines, if the buccal aspect of that implant was actually exposed more, then I would probably push you more towards a ridge augmentation first. So I think you can place it. The only problem with this case is you have to be 100% on the money. Location, mesial distal, buccal, lingual, and apically coronally. Therefore, what I would say is this would be a 2 supported guide, which is the most accurate. I would definitely, yeah, so that's 10.9. It's usually between 10.5 and 11. So that space is perfect for the 5x8. Do a 2 supported surgical guide, and I think you'll be fine with using some autograft and allograft on that facial aspect and build out the ridge a little bit. Okay, does that make sense?
That sounds great. Oh,
Okay.
absolutely. That's
Okay,
exactly.
so what questions do you have for me on that?
No, that's pretty much what we had planned. I just wanted to confirm it with you. My preference is to place the implant and then graft, at the same time, place a membrane. Now, of course, I will decorticate the bone.
Yeah.
To me, I think that, I am definitely going to do it guided so I can be precise.
Yes.
And the 5x8 is exactly the one that we had chosen. So I think it looks good. Yeah.
Okay, so Scott, let me show you a couple other things. So Hussein, can you get rid of that tooth?
Oh, yeah, absolutely, sir.
So let's take the tooth out. So if you look at this, let's look at it on the pan view real quick.
Yes, sir.
Let's go back, Scott. So I want to just show you. So see how that is, I'm going to say just a little bit above the mid-level of the mid-root level of the bicuspid, and probably, well, that molar is extremely long, but it is the crown to implant ratio
Yeah, I was
is
thinking,
not,
yeah, the
not
crown to
ideal.
ratio.
So when you're looking at apically coronally where the implant is, that, on the pan, it's going to be a little deceiving. It looks like it's pretty low, but go ahead, Hussein, and go back to that 3D image.
Yes, sir.
And I believe he was already one step ahead of me. He was looking at the free gingival margin is right here. And Scott, ideally, we should be approximately 2 to 3 millimeters below that free gingival margin, our platform of the implant. And what does that give us?
1.8
Almost
millimeters.
2. Okay, so we're there. We definitely have enough room for our emergence profile. So 1.9, we're right there. I think this will be a home run. A couple little recommendations. Hussein, could you move that 3D model so I can show him the contact areas?
Oh, absolutely, sir.
So Scott, one problem that you have when you have these single edentulous sites, especially when they've been edentulous for some time, is do you see the mesial, the molar, and the distal, the bicuspid? They're not in the same plane, meaning that their guide planes are not parallel. So when you go to prosthetically rehabilitate this, meaning put the crown in, if you don't adjust the contact area, what's going to end up happening is you're going to have 2 paths of insertion, and it's going to be rather difficult to seat the crown. So prior to taking the impression, what I would do is parallel those surfaces. So do guide planes on the mesial, the molar, the distal of the bicuspid, and then you'll have one long contact area on each tooth, and that will be better for force distribution also. Okay, does that make sense?
Absolutely.
Okay, so that's just a little bit of tip. You'll be able to insert this crown in seconds versus adjusting the contact. And then sometimes what happens is after you adjust it to get it seated, then you have a light contact. If you look at, Scott, have you ever heard of what is called proximal contact loss?
Oh, yeah, when the teeth shift.
Yeah, so
Yes.
what ends up happening, some of the most recent studies are showing about 60% of teeth within the first 6 months actually lose their contact. Not all the way, but it'll definitely loosen up to where food will get impacted. So by doing those guide planes, like Hussein had shown you with those 2 lines, that's going to give you a long contact area. You're going to have less of a chance of that contact opening up. Usually the contacts open up because of mesial drift, which happens in older patients. So again, this patient, she doesn't have the best quality of bone, so these teeth can move a lot easier than someone with a lot more dense bone. The last thing I want to show you on this case, Scott, is let's say that you were doing a bicuspid. And this nerve is pretty low, so it is a type 3 nerve. One complication or one variant of the anatomy of this nerve is what is called, okay, he's already 2 steps ahead of me. So this is called the axial image. And what he's going to do is look for what we call the anterior loop. So Hussein, show our audience what you're doing there. So he made a mark, which is a perpendicular line on the anterior aspect of the mental foramen, and he's at the superior aspect of it. Now, Hussein, what I want you to do, can you draw in the nerve?
Yes, sir.
So he has the nerve drawn in. So do you see where that pink is? Okay, go back a second.
Yes, sir. Here we go.
Go a little higher. So we're right at the superior aspect of it. Okay, keep going, keep going. Okay. Okay, now you going inferior?
Inferior right now. That's right.
Okay, so what he is doing, every time he clicks, it's about 1 millimeter. So he's at the superior aspect of the foramen. And what I want everyone to look at is that pink circle, which is the mental nerve branch that's coming out of the foramen. And as he goes inferior, we're looking at the mental canal to see if that goes anterior to that red line. Keep going, keep going, keep going, keep going, keep going. Whoa, yeah, so you do have a little, okay, hold it right there. Okay, let's measure that anterior. So see how that pink is anterior to that red line? So you have about a 2 millimeter, Scott, anterior loop, meaning that the nerve comes forward and then it exits in a posterior direction. Why is that important, Scott? Let's say that we were placing a first molar implant. You have to take that into consideration as your 2 millimeter safety rule. So let's say that this patient was edentulous, we would actually have to go 2 more millimeters more anterior for that more posterior implant position. Okay, does that make sense?
Yes, yes.
Okay. Okay, good. So let me see what else. Anything else that we can show you on this, Scott?
That was excellent. The only other comment I would make is, what do you think about undersizing the osteotomy? How do you think the quality?
Very good. Actually, I meant to even say that. Let's look at the cross section, because I meant to talk about this when the implant was in. So remember, when we place an implant, when we place the implant into the bone, our primary stability comes from the cortical bone, mainly the coronal or the crestal cortical bone. The trabeculi will give us some primary stability, but depending on the quality of bone. The problem with this case is the trabeculi are rather diffuse and very thin. So Scott, I would utilize our D3, D4 protocol on this. What that means is you're going to osteodensify it. You're going to under prep it by at least 1 to 2 burrs and then place the implant. What that will do is that will just give you a little bit more primary stability, and it will change that D4 type of bone into a D3. So it increases it. Instead of drilling the bone away, you're going to laterally condense it so that we have more bone at the implant interface. Okay. Yeah, good. Thanks for bringing that up.
Oh, thank
Okay.
you.
Okay, anything else we can answer for you, Scott? And if anyone else has a question on that case, please submit it to that Q&A down there, and keep the faculty busy. Keep them on their toes. Let me show you one other thing, Hussein. Let's look at it from the occlusal surface.
Absolutely.
And just make sure this implant's coming out where we want it. Okay, so when we look from an occlusal surface, the easiest way to look at buccolingual positioning is extrapolate a line between the central fossa, the bicuspid, and the molar. So he's right on the money. So when I first looked at this case, Scott, I thought that concavity was huge and there was no way we were going to get an implant in, but you just barely were able to do that. Now, are you still there, Scott? Okay. He's off.
Yes, I'm here. I'm here.
Okay. Let me tell you where we used to run into problems. And this is just because we didn't know any better 20, 25 years ago. We would put an implant in like this and just put particulate bone on the facial. We didn't realize that you really have to prep the site. So you have to make sure there's no soft tissue attachments there. Secondly, you want to decorticate it a little bit to get angiogenesis, more blood supply. And that also will give you a little bit of mechanical retention for that bone. So what I would do, Scott, when you're drilling the osteotomy, just save the bone from the flutes of the burr and then add a little bit of allograft in, ideally mineralized allograft. And I think you'll be fine. Just put a collagen, a regular collagen. So you want a regular collagen membrane that has a resorption of about 3 to 4 months. And I think you'd be fine on this. Okay.
Excellent. Yes, thank you so much.
Okay, perfect. So again, any questions, please shoot them over to Q&A. And Hussein, who is our second doctor for tonight?
I think it's Dr. Jimmy Shin for today.
Oh, Dr. Chen, how are you, sir? Is he on?
Yeah, I think he's on, but
Jimmy, how are you?
Hello?
Hello, Jimmy, how are you?
Good, Dr. Resnik. Still tired from our surgery course a few days ago, but
Wow.
I'm good.
I'll tell you what, Jimmy is my favorite. I did a couple, he's come to, I think, every hands-on surgery course we've given. And we just had one last Friday, and he was a superstar again. He's a very good clinician, great set of hands. So thanks, Jimmy.
Thank you.
You make our job easy. So tell me, what do you have for us tonight?
Yeah, so I have a 29-year-old scheduled for implant placement number 30. She's actually an interesting case because she had root canal done with the specialist about 2 years ago, and then she came back 1 year ago with a fracture, so we had to remove the tooth. But this was really careful, so I sectioned it, removed it. It was a five wall defect, so I just did a socket preservation there with a osteo plug from Salvin.
Okay.
And then the surprising thing was it took about a year for her bone to kind of really integrate. And I think it's still a D3, D4 bone, which is kind of surprising because we waited a year. She came back 5 months, 8 months, and I took a CBCT every time. And finally, after a year, I was like, I think this looks good enough. So here we are.
Okay, so so Jimmy, let's do this. Hussein, let's look at it from the occlusal. And let's get rid of the teeth. So Jimmy, if you saw that other case, the first case that we just did,
Yes.
see how invaginated that was? Yours is
Yeah.
not that bad at all. And it's most likely because you did a nice job on the graft here. So it was a 5-wall socket, you treat it correctly, and you maintain that bone. So let's do it, put the teeth back in. And Hussein, let's do a 360 and let's look at our sublingual undercut. So hold on. Okay, so you have less of an undercut here than the case that we saw the last case. So it does look a lot better. I think you'll have a nice column of bone here. So let's go ahead and let's go and look at the panoramic image and let's see what that looks like. Okay, so okay, so let's look at that cross section now.
Yes, sir. Here you go, Dr. Resnik.
Okay, so Jimmy, did you say you use an osteogen plug?
Yes.
Okay, so you do have the buccal plate still. The strange thing here is that trabeculi, the marrow space is very poor bone density. So
Yes.
that's rather significant. So hey, how old is this patient?
29.
29. Wow.
Yeah.
Let's scroll back and forth. Let's look at some other cross sections here, Hussein.
Here you go, sir. I'm moving right now towards tooth number 29.
Okay. So she does have some merit. So she almost has a little bit of like osteopenia going on. Okay. So let's go back to this extraction site. Let's go right here. So we have 8.5 basically width, and then we have plenty of height here. So Hussein, did you treatment plan an implant for this one?
Yes, sir, we did. We added a
what did
5
you
by
put in?
10 millimeter long implant at that spot, Dr. Resnik.
Okay.
Here you go, sir.
Okay, so I like that. I like that. So if you see, I'll tell you what, go one up. Let's go to 11.5. Let me just show you what happens when you get a little too greedy. So Jimmy, see what would happen? We got another 1.5 millimeters, and now we're into that cortical bone where we could perforate. Not worth it at all. And
Yep.
again, you don't have much ability to alter the position. So I would go back to that 10. So I would say Hussein was right on the money on that, right where it is. So now, do we have a tooth on this? Do you
Yes,
have a
sir, we do.
prosthetic tooth?
I'm sorry, Dr. Resnik. I guess I might have deleted it, but I could add it really quick.
Okay, well, no, that's all right. Do we have an opposing on this?
I don't think so.
No, sir. It's only capturing the mandibular arch.
Only capturing the mandible. Okay. So, okay, so let's look at the central fossa then. If we don't have the maxilla, let's look at our central fossa. Okay, so with that being said, if we extrapolate a line through the central fossa, that second bi all the way to the molar, we might be a little bit lingual.
True, Dr. Resnik.
So let's see if we can tilt that a little bit more facial. I think we'll still be all right where we're at, but let's see if we can tilt a little bit more facial here. Just to get that coming out more in the center. Oh, I like that already. Okay, that's good. Leave it right there. Okay, so let's go back and look at that cross section now. So that's perfect right where it's at. So let's look at the cross section.
Here we go, sir.
Okay, so Jimmy, on this, certainly this is a bone density issue also. So the thing that you're gonna notice on this cortical bone, when you drill right through it, it's not going to feel real dense. See how
Mhm.
it's like slightly radiolucent? So it's like a mixed radiopaque, radiolucent. So the cortical bone, even though it has remodeled, is not remodeled to the good thick bone that you see there on the lingual or on the mid facial. So what I would do is treat this as our D4 surgical protocol. Most likely I would under prep it by 2 burrs, Jimmy, on
Okay.
this. And I would also, were you planning on doing this guided?
Yeah. Mhm.
Okay, so I would definitely do this guided just because to get the buccolingual mesial distal positioning of that more ideal. So that you stay right as that this has been treatment planned. Okay,
Okay.
so let's see, is there anything else? Hussein, did you find anything else on this case that was interesting?
The anterior mandible is very
Oh, okay,
interesting.
hold on. Jimmy, look at that. See how, just like that other case, make sure you do some guide planes on that.
Yeah.
And some long contact area. You're 10.9 again, which is the normal first molar. And with a 5mm implant, you'll have no problem getting a nice emergence profile on that if it's positioned right where it's at.
Great.
What was that, Hussein? You said you had some.
We had a very interesting anatomy at the anterior mandible, Dr. Resnik.
Oh, okay.
Here you go,
Okay.
sir.
Scroll through. Okay. Oh, go back. Hold it right there. Okay. Go back. Go back. One more. Go back. Keep going. One more click right there. Hold it. Hold it. Nope. Go back. Right
I'm
there.
going, here we go, sir.
Okay. So put your show them the opening there. So this is at the midline. We're in the midline.
Yes, sir, we're exactly at the midline.
Okay. So what he circled there is called the mandibular lingual vascular canal. And the opening actually on the lingual aspect of the mandible is called the lingual foramen. Inside that lingual foramen is what is called the vascular canal. And it's usually the midline lingual vascular canal. It's almost always on the midline. And what it is, it's the right and left sublingual arteries. And they anastomose right in that area. So if you scroll through here, go each way 1 or 2 clicks. Keep going, keep going, keep going. Ooh, oh, that comes through the, go back. Okay, that comes through more apical. This is a really neat one. So, okay, go back to our first opening, which is the origin of it. Okay, so if you look at that little radiolucency, show them that with a pointer. Okay.
Sorry, I went a little bit.
Yeah, that's all right. Just show them with your white, the cursor. Okay. And then as he clicks, what happens is these arteries transverse through the mandible. Sometimes I've seen them go up, actually coronally. They'll go up right by the teeth. This one comes almost to the midpoint of the mandible. And then it looks like it takes a nosedive apically. So click a couple,
Here we
do
go,
about
sir.
2 or 3 clicks right there. Perfect. And it comes through the actual lingual aspect of the mandible. Okay. So this one transverses. So why is that? Why are we even talking about it? Well, let's say, Jimmy, let's say that you didn't have teeth here and you were putting a implant in the midline for an overdenture. Those arteries do tend to bleed a little bit more than normal. You would see some rather significant bleeding through your osteotomy. However, that's inside the bone. So intraosseous bleeding is a lot better than extraosseous bleeding. So where the first case we talked about today, I was worried about hitting the submental artery back in the molar region and having a sublingual hematoma. You would not have that problem here as long as you stay within the confines of the bone. All that you would do to stop the bleeding would be to either place the implant, place a drill, or place a direction indicator, anything that would allow the body to clot it off. Hussein, could you look on the 3D model and let's see if we can actually see this come through the lingual? Usually you don't see them like that. Oh yeah. Okay. Oh, here, perfect. So show them with the cursor, the lingual foramen. Okay, see that little opening? That's called the lingual foramen. That's where the right and the left sublingual arteries come in. And here is where they exit out the lingual aspect. Okay, now there's another variant here. Oh, right there. Oh, right there. Okay, so let's enlarge that so they can see that.
Yes, sir.
Okay, see that little opening? So, well, I can't ask the question because we can't have people answering it, but let me tell you what that is. That is an aberrant nutrient canal. We have numerous ones. So what happens as the infraalveolar nerve transverses anteriorly, it has the two terminal branches, which is the mental nerve and the incisive nerve. But it also has dental alveolar branches that are wound around those sensory nerves. So what these are nerve, artery, and vein that would normally go to a tooth, but they're aberrant, meaning they're in the wrong position. So what happens is most likely when this patient was developing in their growth period, one or more of these small little aberrant vessels just perforated, went through the lingual aspect. Nothing to worry about, not at all. It's just something that we see now and then. Okay, but those usually go to the teeth, and they give the nutrients either the nerve, artery, and or vein. Okay, so anything else on this one? Jimmy, do you have any questions or any other comments on that?
Well, not related to this case, but the previous case, you talked about decortication for some buccal graft. I was just wondering, apart from scraping the cortical plate on the buccal side, do you want to drill a few holes through the buccal plate, or just scraping the bone?
You know what I like to do on those, Jimmy, is use like a 169. That would be like a tapered crosscut Fisher burr, or you can even get like a half round burr and make small little decortication holes. You don't want to use like a 171 or anything like that because the holes would be too large. So you want smaller holes. And just for some of the doctors on that have not heard me talk about that, what that does when you decorticate, it brings blood into the area. Also, it allows angiogenesis to occur faster, meaning that it forms newer blood vessels faster. And that just makes the healing more predictable and faster. So, Jimmy, if we go back to the early days of implants, the reason why we had this wrong, we never knew better, that we would put it right over cortical bone. But if you think about it, you have that thick cortical layer of bone. How do blood vessels perforate that? We get all the blood from the periosteum. And that's why some of our grafts didn't heal as well as we like. Now we look at, think of the healing, Jimmy. So you put the bone there. We need to get blood there, because what blood has cytokines and growth factors that it brings to the site. And it allows us to nourish and start the remodeling or regeneration process. So with that being said, by perforating, now we're getting extra blood supply. We're getting it from the cancellous spaces, and it it heals a lot better and it's more predictable. Does that make sense?
Yes, and so sometimes what I'm thinking is, like, let's say with the previous case, if you drill through the bone, the cortical bone to get to the cancellous, would it affect the implant itself? Like, I feel like the implant would be in the way, or it really doesn't
No,
matter.
so think of the angulation. You're going to go more, you're going to angle it more inferiorly so that
Okay.
you're away from the implant.
Okay.
Okay, you could actually drill, and I know some people do that, but ideally you don't do that. And you can go, so see, let's say your case here needed bone, or we had to decorticate it. I would decorticate on the mesial and on the distal significantly, okay? And then over top of it, if you look at it, let's look in an occlusal view, Hussein. And can you make it radiopaque? Okay, so see how you could see how it fans out in more like a triangular morphology. So you can actually angle your burr so it's away from, it's more on inferiorly, but going buccally to the implant. Does that make sense?
Yes.
Okay. Okay, good.
And then in that case, would you still kind of release the flap so it covers the whole thing, or
Yes, I
okay.
mean, ideally, anytime we graft, we always want to release. Now, where we have problems, as you know, is when we do immediate placement, because then it's very difficult to get primary closure. But on this one or the case prior, both of those cases, I would definitely get primary closure, and you could do that very easily. So your incision, even though you don't want to release it over top of that nerve, you can do just a small little release out to the facial of that molar, and you can rotate that flap over, and you just undercut it a little bit and just sever those periosteal fibers, and you would have no problem covering a small little bone graft with that.
Sounds good.
Okay, anything else?
Yep. No, that's it. That's it for me.
Okay, nice job on Friday. We'll see you
Thanks a
again
lot.
soon, I'm sure. Take care.
Yep.
Okay,
Thank you.
Hussein, oh, wow, we're running out of time. Let's get to another case.
All right,
Yeah,
Doc.
now.
So we have next Dr. Nicholas Nieto.
Okay. Hi, Nick, how are you? Is Nicholas on?
He is, I think he just needs to unmute. There we go.
Hello, hello.
Hi, Nick, how are you?
I'm very
Okay.
good.
Hey,
I
Nick,
didn't
could you
expect
tell
the
us a
call.
little
Thank
bit
you very
about your
much.
case?
Well, this
Can
is
you take the implants out, Hussein, please? Okay, perfect.
this is
Okay,
a
tell us a little bit about your case here.
Yes, this is a 68 years old lady, a female. After I was analyzing the CBCT scan, I asked more about her medical history, and she
Okay.
said that taking
What's her medical history?
she's taking Fosamax.
Okay. Do you know how long she's been taking Fosamax?
Yes, I asked that question, and it's in December. It's been 3 years, so since December 2019.
Okay, so we're looking 3 going on 4 years. So, okay, so what? Any other issues medically?
No, she's controlled with high blood pressure. She's taking 81 milligrams of aspirin, and she's
Okay.
healthy otherwise. So my concern is that for bone density.
Okay, so let's look at Nicholas. Let's look at the bisphosphonate. So she's on an oral bisphosphonate, which is a lot better than an IV bisphosphonate. If she was on Zometa, which is the more popular IV form bisphosphonate, she would be a contraindication. Now, the only thing that concerns me a little bit, and I say a little, is that she's been on it approximately going on 4 years. The reason why the time duration is an issue is that the half-life of bisphosphonates are cumulative, and they're a lot longer than what they ever were thought to be. It is most likely over 10 years now. So she's been developing a buildup of this bisphosphonate, which alters the osteoclast activity. And if you look at some of the literature, potentially it could turn into what we call an osteonecrosis. However, if you look at the latest studies, Nicholas, the systemic reviews and the meta-analysis studies, which look at a full range of studies, they take a cross-section of the better studies, and they come up with basically a conclusion. The chances of developing an osteonecrosis from oral bisphosphonates is rather low, where it's what we call a relative contraindication. A relative contraindication means that you can go ahead and proceed with the case. You just have to take certain precautions. So what I would recommend is, Nicholas, you've come to some of our classes, haven't you?
Yes, I went to the CBCT bootcamp a couple of weeks ago in Orlando.
Oh, okay. Okay. So I probably didn't talk about it then, but if you look at either one of my textbooks, or if you email me, I will send you a bisphosphonate consent form, which is a very good specific consent form. So what is standard of care, Nicholas, is that you inform this patient that there is a very low chance of developing an osteonecrosis, but there's always a chance. And that is, you need to do it orally and also in writing. So you use my bisphosphonate informed consent. You write in your notes that you verbally, you orally, and written informed consent, and then you're covered there. Second thing I would do is get my medical consultation form, and I might have given that to you if you went through that CBCT course, but send that to the patient's physician and just make sure there's nothing else going on with this patient. There shouldn't be an issue with it. Most of the times they don't even give the patient a drug holiday, but that is another option. So what I would do is go to either one of my textbooks. I have pages that I've both sections in both textbooks on this, but your options are to possibly do a drug holiday. And again, that would be through the patient's physician. The second option would be what is called a CTX test. That is a blood test. Both of those have been, if you look at the literature, have really questionable validity in the literature, but I would go more on what the physician would recommend. So I would let the physician know the patient's going to get implants and go on their recommendation, whether they get a CTX test, whether they do a drug holiday, or whether they say there's no problem at all. Okay?
Okay.
Does that answer your question on that?
Yes, yes.
Okay.
I
So
got your book. So I got your book. I've been reading about it, and then got me really concerned about that.
yeah,
Because it was
but
more
this
than 3 years.
is, like I said, it is really not a big concern at all. It's, you just have to watch the patient more closely, and inform the patient of the very low risk, but I think you're fine. And you can email me too, and I can help you with that further if you decide to do this case. But we don't have a long time to go. We only have a couple minutes left on this. So tell me what your plan was on this case. So go ahead. Could you put the teeth back in, Hussein?
Yes, sir.
Was to place 2 implants 19 area to 21 to do a 3-unit bridge. Patient has an
Okay.
open full denture.
Okay, good. So that's the first thing I was going to ask you. So Nicholas, if this patient was a 350-pound linebacker with parafunction, you would say you would put 3 implants in. This patient is a female, was that correct?
That's correct.
Yes, female with how old again? 60,
68.
68. So as you know, patients as they age, especially females, their biting force decreases significantly. What is even more positive on this case is that it's opposing a denture. So we know that natural teeth in the first molar region can apply 250 plus pounds per square inch. We know when you edentulate them that they go down to about 50 pounds per square inch. And then every year thereafter, they're edentulous, their biting force decreases. So this patient has very minimal biting force. So doing a bridge, implant bridge is right on the money. So I like your treatment plan. So did we put any implants in on this one, Hussein?
Yes, sir, we did. We added 2 implants, number 19 and 21 position.
Okay.
Let me start by
So I
showing
like
number
where
19,
those are
sir.
placed. Let's look at, okay. So what is this? This is a 5x10. This is 19.
Yes, sir, that's
Okay,
affirmative.
scroll
That's a
back and
5x10.
forth on this one. Okay, back the other way. Okay. So hold it right there. Okay, so just for our audience, this patient definitely has osteoporosis, not osteopenia. Hussein, show them that buccal cortical bone where it's modeled. See how there's a radiolucency there inside the cortical bone? That is what we call modeling, and that is consistent with osteoporosis. The second component of osteoporosis is when you lose the trabecular bone. So as you can see, there's very minimal to no trabecular bone. In fact, this inferior alveolar canal or mandibular canal there is no canal. It's the nerve, artery, and vein or all the fascicles, they are just laying there. There's basically no bone around it. So going back to this, Nicholas, show me real quick number 21.
Yes, sir, that's number 21, Dr. Resnik. A full
Okay, so
5x5.
21 looks good. I like where 21 is. 19 is going to be a little bit more challenging. These are hyacinth implants.
Correct, Dr. Resnik. These are hyacinth.
Okay. So Nicholas, here's take that implant out for me, please.
Here you go, sir.
Okay. So Nicholas, the only, and I know you haven't gone through the first surgical course, but you can read in the textbook, in the surgery textbook, that's the latest one. Look at D4 surgical protocol, and you're going to under prep this by two drills, and then basically place the implant in a undersized hole. Okay, so you're going to osteodensify it. The reason is the bone density is very, very poor here, rather significantly poor. The problem that we have with osteoporotic patients, Nicholas, is that you'll place the implant, you'll get good primary stability, but what ends up happening, if you think about the interface, what ends up happening is the bone that is around the implant or in contact with the implant, what we call the bone implant contact, BIC, will start to resorb. As it resorbs, more new bone will start to develop. So at approximately 4 to 6 weeks, Nicholas, this interface is the weakest. And what can happen in these osteoporotic patients, and I have a full, if you look in the textbook, I have probably about 3 or 4 cases of it, where the implant will actually sink. So you lose your primary stability, and while you're waiting for the secondary stability to grow the bone and integrate the implant, it actually loses its stability in the bone and migrates apically, which can be a problem when you have a mandibular canal with no bone or no covering on it. So the bottom line is, when you place these, under prep them by a minimum of 2 burrs. Okay.
Okay.
And I like where he has them positioned. I would also do this. I would do it guided, definitely, on this, because you don't have much margin of error here, just because of the resorption pattern of that posterior mandible. Okay. What questions do you have, Nicholas, for us?
No, that was the position of the nerve that was not clear in the CBCT scan.
Yeah.
yes,
So what they did is, all of ITX's planners, they're all dentists. They're very, very good. And what they can trace the nerve. What they do is, we don't have time to do it, but what they do is they'll go back to the model. They know where the nerve is coming in on the lingual surface by the lingula, and then they know where it comes out. So they'll work in 2 directions, and then they'll connect the 2 points. So see where he can see just barely where the canal is, and then he knows where the nerve comes in, and then he can trace it image by image. It takes a long time to do, but they're very good. They're the best at it that I've seen. Be very careful in a case like this. Let me do basically a warning on this. I see a lot of local labs, smaller labs, that they'll draw these nerves in, and you have to be very careful. Always make sure that your nerve is in the right position. This is a very difficult one to identify. I would say on a scale of 1 to 10, this is a 12 in difficulty, but as I said, Hussein and Sarah, they are experts at it. So they're right on the money. So I would say this plan, Nicholas, you're good to go on it. Okay.
Thank you. Thank you very much. I really appreciate
Okay.
you.
Well, Robert,
Thank
I'm
you.
sorry we went over a couple minutes, but do you want to do a couple? Do we have any questions that you want to ask before everyone calls it a night?
Actually, the faculty did a great job in answering. We had about 35 questions, Doc.
Oh, you
and-
did? Okay,
Yeah.
I like it. Make them work a little bit. So,
And so, I mean, I don't know how much more you can make them work after what happened last Friday, but
okay. Well,
but there is one, I think, question. I see Dr. Amin answering it, but the question is this correct? Oral bisphosphonates are relative contraindications? Is that
yes,
correct?
so oral bisphosphonate is a relative contraindication. An IV bisphosphonate, whether it's for metastatic cancer or multiple myeloma, the most common is Zometa, is an absolute contraindication. Now, they also use Zometa for osteoporosis. Some of your patients might be on Reclast, and that is a once a year injection or IV infusion. That is an absolute contraindication, mainly because the FDA has put a black label on it. However, for Beniva, Fosmex, Actonel, those are all oral bisphosphonates, relative contraindication. You just have to do, I would follow my protocol in the textbook or email me and I'll give it to you, but not a problem at all. You can still do it. It's not a problem.
Okay, excellent. We are getting a couple more in. Here's one. Do you have to fix the collagen membrane with tacks to stabilize the graft, or will it be stable enough without tacks?
So on a small graft like that, you really don't need tacks. What I would highly recommend is you just do a little bit of a lingual reflection and you tuck it under the lingual flap. You're going to tuck it under the buccal flap and cover the particulate graft, but tuck it under the lingual. And the newer collagen membranes work very, very well, especially if you hydrate them early enough. They sit very well that you shouldn't have to tack that at all. To try to tack that would be rather difficult. And we're doing more and more less tacking. Where we used to tack, we would put 4 tacks on every graft. We're doing less and less just because of the quality of the newer membranes.
Excellent. Thank you for that. I do see Dr. Robinette answering this, but here's another one. Some say using osteogen instead of membrane. What is your opinion?
Yeah, the osteogen, the problem you have with osteogen is if it's a 5-wall socket, you're all right because you have the buccal plate. Where I see problems is people using an osteogen plug when they have a very thin buccal plate or it's absent. And you have to treat a 4-wall socket differently than a 5-wall socket. So I see a lot of socket grafts that don't work, and I can almost guarantee you why they don't. And that's because it's a 4-wall socket that's being treated as a 5-wall. So you need to, if you just Google my name and 4-wall extraction sockets, it'll show you how to do it. You have to use a longer acting membrane, and you have to do a different protocol than your normal socket grafting for that.
Okay, thank you, Doc. Contemporary Implant Dentistry 4th edition book is the latest one, or is there a newer one than that?
No, that's the newest one that came out in 2020. Later this year is the prosthetic book that will be coming out. So the surgery book is completely updated. The pros book is going to be updated. It'll be coming out later this year. The complication book came out in 2017, and that's on my agenda right after the pros book. So there'll be a new edition of that coming out.
Well, we know you are a very busy man, Doc, and we really appreciate your time to educate us all on how to properly, treatment plan our patients and provide them with the best dental care. I just want to remind the folks out there that S4 is coming out. Is going to be in May 19th and 20th, and that is going to be the surgical session, the next surgical session at the Resnik Implant Institute, which is treatment of the posterior maxilla, osteotome, and lateral wall techniques. So make sure there are limited seats available. Make sure you contact the Resnik Implant Institute to sign up for that. And then also April 20th will be our next webinar, which we will be treatment planning more cases. So please be on the lookout for that email, as well as have your cases ready to submit so we can treatment plan live with Dr. Resnik.
Yeah, so if you have a case, so we're looking at aesthetic zone cases. Is that what the
Correct,
next one is?
Correct.
So either preferably a maxillary anterior or a mandibular anterior. Let's get the cases to ITX. We're going to do them just the same ways we did tonight. A lot of people really like this. For people who have never heard this before, Robert and I or Hussein and Sarah, we do this at every one of our courses. And I think our record is 62 cases in one weekend we did.
Yeah,
but
I think
it's a very good learning experience because you see what other doctors are thinking. You get our input, the faculty input, and then we have a group discussion. I'm very CBCT oriented, so I always try to point out abnormal anatomy, variant anatomy, pathology, things like that. So usually we will see that, and we did see a couple variant anatomies today. So, but
Yeah,
anyway, thank you, ITX. You guys do a great job. And I can't tell you, we did 36 surgeries on Friday, and you guys were involved in every one of them, and everyone went perfect. So thank you for all your
Our
work.
pleasure, Doc. It's our pleasure. And just be on the lookout for your CE credit, as well as a special webinar promotion from ITX, where you can save 30% on your first guided case with us. So with that, I would like to thank everybody for joining us this evening, and we hope to see you next time. Thank
Okay,
you.
thank you.